Welcome to The Explainer. Today, we're diving into an organism that's really making microbiologists stop and think. It forces us to ask a really critical question. Is this just a simple contaminant, or are we looking at a serious pathogen? Yep, we're talking about Corynebacterium durum.
This is the big question we're all facing now. When this thing pops up on a culture plate, it's really shifting its whole reputation, right from what we thought was just a harmless commensal to what we now know is a pretty sneaky opportunistic pathogen.
So in this explainer, we're going to cover everything from what you see on the bench to what it means for the patient at the bedside. All the info comes from a Gemini deep search, and if you want to see the full list of sources, just check out the notebook document we've linked for you.
All right, first up, let's tackle the lab identification puzzle. And trust me, getting a definitive ID on Corynebacterium durum, well, it can present some real challenges.
Okay, so when you're looking at the culture plate, a few things should really stand out. First, it's a slow grower, so you got to be patient. Don't be too quick to toss those plates. The colonies are also famously adherent. They're so tough to get off the agar that it's actually a useful clue in itself. Then, under the microscope, you're going to see that classic pleomorphic, sometimes filamentous, gram-positive rod.
And that filamentous morphology, that is the #1 diagnostic pitfall. It looks so much like Nocardia species, it's easy to make a mistake. In fact, that's exactly what happened in a documented case of cavitary pneumonia. And look, this isn't some minor error. The treatments for nocardiosis and a corneobacterial infection are worlds apart, so getting this wrong has some really serious consequences for the patient.
So for a truly definitive ID, you've got to go molecular. Now, 16S rRNA sequencing, it was foundational for sure, but it just doesn't have the resolution to tell these closely related Corynebacterium species apart. And that's exactly why the clinical standard has shifted to sequencing the rpoB gene. It's way more polymorphic, which means it gives us a robust, unambiguous, species-level identification. No more guesswork.
Now, if you're still running biochemicals in your lab, there's one key test you absolutely have to remember: mannitol fermentation. Corynebacterium durum is positive for it, and that's a pretty uncommon trait among its relatives, so it serves as a really strong clue during your workup.
Okay, so we've got an ID. What does that actually mean for the patient? Let's dive into the clinical side of things and really understand the disease spectrum of this opportunistic pathogen.
The story of how we understand Corynebacterium durum has followed such a classic path. It all started back in 1997, when it was just seen as another commensal hanging out in the oral pharynx. But then, reports started coming in from sterile sites, and more well-documented cases piled up. All of that has really solidified its role as a recognized opportunistic pathogen.
And the list of diseases it can cause has expanded a lot. We now have confirmed cases of really severe infections, like bacteremia and that cavitary pneumonia we talked about earlier. And honestly, given how its relatives behave, it's pretty darn plausible that it's also the culprit behind some device-related endocarditis and osteomyelitis cases.
Right, so this infection is almost always opportunistic. That means if you isolate this from a patient with those key risk factors, we're talking profound immunosuppression or an indwelling device, you've got to take it seriously and get that clinical correlation. This is absolutely not an organism you can just reflexively dismiss as a contaminant in these patients. No way.
Okay, let's switch gears and talk about treatment. Now, this is where things get a little complicated, because just like so many other non-diphtheria Corynebacterium species, this bug has developed some pretty widespread antimicrobial resistance.
And I have to say, that historical susceptibility profile from back in 1997, it's dangerously misleading today. Those original isolates were sensitive to just about everything. But fast forward to now, and large surveillance studies tell a totally different story. Widespread resistance to penicillins, macrolides, and fluoroquinolones. That's the norm now.
So what does that leave us with? Well, it makes vancomycin and linezolid the absolute cornerstones of your empirical therapy. If you even suspect this organism in a serious infection, these are your go-to agents. Their susceptibility rates are nearly 100%, so you can count on them while you're waiting for those AST results to come back.
Of course, for definitive therapy, you absolutely need to do formal antimicrobial susceptibility testing. That's non-negotiable. And to interpret those results correctly, you have to use the right standards. What you're seeing here are the current UCAS breakpoints for non-diphtheriae Corynebacterium species. These are what you should be using to guide your targeted treatment.
So here's the thing.
There are no specific guidelines just for Corynebacterium durum. So what do? We extrapolate from guidelines for similar infections. A great example is the Dutch SWAB guideline for prosthetic joint infections, or PJI. And really, across the board for infections like catheter-related bloodstream infections or prosthetic valve endocarditis, the principles are exactly the same. First, you focus on source control, get that line out. And second, you use prolonged therapy. And of course, you always have to carefully adjust those doses for pediatric patients.
All right, we're almost there. Finally, let's quickly cover infection prevention and control, and then we'll wrap this all up with the key takeaways. When it comes to infection prevention and control, the strategy is all about risk stratification. Of course, standard precautions are the foundation for every single patient. But here's the important part. We know that related species can cause nosocomial outbreaks, so it's just smart to have a lower threshold for implementing contact precautions, especially for those vulnerable patients in high-risk settings, like the ICU or on oncology wards.
At the end of the day, the story of Corynebacterium durum is just such a powerful reminder to always question our old assumptions, right? If you found this explainer useful, please let us know what you think in the comments. Your engagement really helps us create more of these. And don't forget, all the sources are in that linked notebook.
And that really leaves us with a final crucial question to take back to our own practices. Which other so-called commensals that you see in your lab every day might just deserve a second look?